We are going to get started in about 5 minutes and give some folks, more folks a chance to sign in. But thank you for being on time. All your phone lines should be on mute for the beginning of the session, and there'll be an opportunity for questions at the end of the session. If you have any questions right now, feel free to type them in the chat box to the right of your screen, and we will answer them as soon as we can. I'm going to go ahead and put everybody on mute until we start in another 4 minutes. Hello, everybody, and welcome to the webinar entitled Prepping for the Future, an Introduction to PrEP, Key Implementation Considerations for Healthcare Organizations. My name is Mazdak Mazari, and I'm a Senior Project Manager at the Primary Care Development Corporation's HIP and Healthcare Program. I'm very pleased to have Stefan Perez with us for this presentation. Before I hand it over to him, I wanted to tell you a little bit more about our organization and our program. And I also wanted to let you know that this session is being recorded for quality assurance purposes and to make available for folks who are not able to attend today. So we are PCDC, the Primary Care Development Corporation, founded in 1993. We're a nonprofit organization dedicated to expanding and transforming primary care in underserved communities to improve health outcomes, lower health costs, and reduce disparities. We have 2 offices based in New York City and Southern California and work nationally through 3 different programs. We started out as a community development financial institution, and a lot of folks like to hear about our program to provide low-interest loans to primary care settings who want to expand their services. We'll let you know a little bit more about how to access some of those services at the end of this webinar. We also do work around performance improvement and quality improvement, as well as policy and advocacy around primary care issues. And this webinar is being supported by our HIP and Healthcare High Impact Prevention and Healthcare program, which is funded by the Centers for Disease Control and Prevention to provide free capacity building services to healthcare organizations across the country. If you're interested in some of the topics that we discussed on this webinar, you're able to access free tailored one-on-one support for your particular healthcare organization. We'll talk about how you can do that at the end of this webinar. But with that, I would like to let you know a little bit about participation on this webinar. We definitely want to hear from you. We also want to make sure that Stefan gets through his presentation. So phones will be muted during the presentation, which will last about 35 minutes. In the meantime, if you have any questions, please type them in the chat box to the right, and we'll do our best to answer any questions you might have in the final 10-15 minutes of the session. Stefan has also graciously agreed if we have more questions than that, we can stay a little bit longer through the hour, but want to make sure if folks need to leave that they have the opportunity to do that. Alternatively, to typing in your questions, we'll open the lines at the end of the presentation, and at that time you can answer them directly. So without further ado, I'd like to introduce Stefan Perez. Stefan has been working in HIV and AIDS nursing for the past 10 years. In this capacity, he has worked both clinically and programmatically and had the privilege to work with dedicated healthcare providers all over the country to implement high-quality and cost-effective HIV care. He's currently a doctoral student at the University of Pennsylvania, where he was recently named a Robert Wood Johnson Foundation Future of Nursing Scholar, and we're very happy to have him with us today. Thank you, Stefan.
Thank you, Mazdek. Thanks so much for that introduction. I'm really excited to be here with PCDC and with you all. I'd like to take just a quick moment to thank PCDC for their ongoing work in this area and capacity building around HIV care, and definitely thank the CDC for their ongoing support of HIV services around the country. As Mazdek said, my name is Stefan Perez, and I'm here this afternoon to talk a little bit about pre-exposure prophylaxis and really prepping for the future. And today's talk is going to talk a lot about some of the basics of PrEP, but also what are some of the keys and pearls that we've been seeing out in the community around the implementation practices and implementation science around PrEP and integrating it into the primary care setting. And we'll talk about some literature around that and also some pearls on how to start making that process happen in your setting. So I want to talk a little bit about prepping for the future, but really the future is here, and I think all of us on this call understand that. Really PrEP is something that is being implemented, it's being talked about, and it is one more very useful, very safe and effective tool in our arsenal for HIV prevention. So as we look at PrEP, we're going to sort of frame it in this method here. We're going to start by looking at a few questions about pre-exposure prophylaxis, what it is, what are some of the ideas behind it, and why do we need it? When did PrEP itself become available? What was the timeline around the evidence and the availability of PrEP? And then who is PrEP for? And then the second part of the webinar, we'll talk more about implementing PrEP and how we can bring PrEP to our community providers and our patients. Now, I always usually like to start any kind of a talk or webinar by really making the topic that we're talking about relevant and looking at what's going on today in our country and in our world. And as for many of you, I'm sure, on the call, it's a little disheartening for me that I'm able to open the webinar today with this type of a headline. But I'm sure, as a lot of you know, an area of southern Indiana with somewhere around, I think, 4,300 people in the community is experiencing what is a true epidemiologic outbreak of HIV infection, with about 80 cases, 71 confirmed, and I think 9 preliminary positives. This is all, based off of reports that are coming out of the region. And what's difficult for me as a provider, and as I'm sure for many of you, is looking at what's being put out there by the media and what's coming out of this area, is that a lot of providers in the area have said that they've recognized an epidemic of injection drug use, and that they saw something like this as a potential possibility in this region. And I'm not going to spend much more time going into the details around what the providers and patients in that area are facing. But there does seem to be a very important element of stigma and politics and geography and resource availability that sort of helps to become a perfect storm for this kind of an outbreak. And I think what it illustrates that's very timely for us today is that while we have fantastic evidence-based tools to prevent HIV infection, many people in our society are still at the mercy of their surroundings. They're still at the mercy of the resources that are available to them and the availability of these prevention efforts. So really our duty tells us that we have to continue to strive to give our patients in our communities as many safe and effective options as possible so that they can protect themselves. So with that, I'm going to begin at the true beginning here and really talk about what PrEP is. And PrEP, as you probably already know, is pre-exposure prophylaxis. And it's an FDA-approved HIV prevention strategy for people who are HIV negative and who are at risk of getting HIV. And these people take approved antiretroviral therapy to prevent HIV infection. And there's a couple things that I just want to highlight there. I want to highlight that this is a treatment for HIV negative people, so it's not indicated for people who are already HIV positive. That would be just antiretroviral therapy. And that this is a type of antiretroviral therapy that has been shown to be safe and effective in persons with HIV infection. So this is really important because this means that the treatment that we're offering to HIV-negative people, we have a long history and background about already in the literature and in the evidence and in our patient population. Currently in the United States, the approved regimen for PrEP is Truvada, which combines 2 different anti-HIV drugs, tenofovir and emtricitabine. And the indication is to take the medication once a day. The goal of the medicine, of course, is to prevent HIV infection in the event of an exposure. And as I said, Truvada has long been an approved antiretroviral and has been proven to be safe and effective in the HIV-positive population, and as we'll talk about in the literature, also in the HIV-negative population as well. So PrEP is a little bit different from post-exposure prophylaxis, which I'm sure many of you have heard of as well, and then a sort of subclass of post-exposure prophylaxis, non-occupational post-exposure prophylaxis, so PEP and NPEP. Those are antiretroviral combinations that are indicated for treating people who have a known exposure to HIV, either in the occupational setting or in a non-occupational setting. So these medications are given after an exposure occurs, whereas pre-exposure prophylaxis is given before the exposure occurs. And I know this seems like a really simple concept, but I really wanted to make it, to sort of hammer it in a little bit, because I think sometimes in the community it still gets a little bit confusing with all the PrEP and the NPEP and the PEPs. So I just wanted to kind of clarify that really quickly. Okay, so now why do we need PrEP? And this is probably a question that maybe some of you have asked yourself. I know, many researchers have asked themselves these questions. There's communities, advocates that are asking themselves these questions. And so this is a very significant question. And what we're going to talk about is starting off by looking at the continuum of care. And I know that most of you have probably seen some version of the HIV care continuum. It came out in about the first real iteration of this came out in about 2011. And since then, there have been all kinds of different care continuums, from local to national to race and ethnicity-based care continuums. But this is a standard one from the Centers for Disease Control, looking specifically at 2011 data. And as you can see, we continue to have somewhere around 1.2 million people in the United States living with HIV. And of those, about 86% have been diagnosed HIV positive. But when you look all the way to the right of this graphic here, you can see that only 30% are engaged in treatment, prescribed antiretroviral therapy, and virologically suppressed, meaning that their viral load is undetectable. And as we know from some other pretty significant landmark studies, that only when a person is virologically suppressed is their chance of passing HIV to someone else the very least. So that means that once they're virologically suppressed, their odds of passing HIV to someone else is very, very low, which is a very significant public health breakthrough. And so we know that if only 30% of the people living with HIV in this country are virologically suppressed, there's a large window there for infections to take place. And so we need to continue to push every available prevention effort that we have. One of the significant things about these continuums is that it allows us to look at these types of percentages over time. And when trended over time, you can see that we have made some good efforts, particularly around virologic suppression. But when you look at the true statistical differences between these percentages, the CDC actually calls this continuum very stable, which is not always a good thing. We think of a stable patient being, that's a good thing. But when we look at trying to change the direction of the epidemic, we don't want to be stable. We want to be making change. And what this graphic shows is that we have made some efforts, but we need to continue to make more. So why to ask someone to take a pill is a question that I think, again, many of us have heard, and maybe some of you have even debated with some of your colleagues. I know I've sat around the table at very informal meetings and dinner conversation, and this topic has come up more than once, just among friends and also among colleagues. So it's a pretty significant issue. We already know how to prevent HIV, right? But one of the things that we know is that HIV infections still occur, and traditional methods are not always feasible. Remember in the beginning we talked about access to other types of prevention methods, and sometimes those prevention methods aren't always there. They aren't always available. It's not meant to be a replacement for other types of prevention efforts. And we know from literature that this is an effective tool for preventing HIV. But won't this make people more likely to take risks? Well, I think that's probably one of the more pervasive arguments here. This sort of increased disinhibition, I think, is what it's actually called in the literature. But one study has actually showed that condom rates increase and sexual risk decrease when people were on PrEP, and there's a lot of data to support this from the Outbreak and partner studies, which we'll talk about in a little bit. But education is really essential. Remember, this is one tool in the arsenal. So education is also meant to supplement PrEP, and it's not meant to be only one intervention by itself. Now, there is some interesting anecdotal information coming out looking at this type of disinhibition behavior, but again, all of it is really anecdotal. So we can't really extrapolate a lot of information from some of the things that we're hearing. We really needed some good evidence base. Next, I'd like to move on to sort of looking at the timeline of pre-exposure prophylaxis. And I want to start a little bit, just giving a little bit of background of the research timeline, looking particularly at 4 really key studies around pre-exposure prophylaxis. The first being, of course, the Outbreak study, which I'm sure many of you have probably heard about or read about. This was a study looking specifically at gay and bisexual men. And those who were given PrEP were 44% less likely to get HIV than those in the placebo group. Among men who had detectable levels of medicine in their blood, meaning that that was used as a proxy for adherence, PrEP reduced the risk of infection by as much as 92%. So significant reductions in HIV risk for HIV infection. In 2012, there was a TDF2 study which took place in Botswana among heterosexual couples. And again, PrEP had some very significant results, reducing the risk of getting HIV by 62%. And again, participants who became infected had a far less level of drug in their blood as compared with the participants who remained uninfected. So suggesting that there was some relationship between adherence and decreasing the risk of infection. And then again, in 2012, there was also a partners PrEP study that looked specifically at serodiscordant couples or magnetic couples, as you may have heard of. This is where one partner is positive and one is negative. And those who received PrEP were 75% less likely to become infected than those on the placebo. And again, sort of the same sub-analysis findings looking at those who had higher levels of medication in their blood reduced the risk of acquiring HIV even farther. And then finally in 2013, another significant study looking at injection drug users out of Bangkok showed that tenofovir reduced the risk of getting HIV by 49% in this population, again with a similar sub-analysis looking specifically at those who had higher levels of tenofovir in their blood. So what have all these things sort of come down to is that PrEP is an effective and safe tool that offers a high level of protection against HIV when adherent to daily medication doses. And that's really the bottom line that I want to hit home to all of you today, is that PrEP is safe and it's effective and it's been shown to work in our most at-risk populations. Looking specifically at the sort of release of the guidelines in that timeline, in January of 2012 was the first real interim guidance for MSM populations that came out that from the CDC and the MMWR that showed that, or that suggested that Truvada taken orally once a day as PrEP was safe and partially effective in reducing HIV acquisition. Again, particularly in that MSM risk group. But then, as the years kind of went on, and more data came out showing the efficacy of this intervention. In August 2012, interim guidance came out for heterosexually active adults, and then in June 2013, interim guidance for injection drug users as well. And then last year in 2014, which we'll talk about, I believe, in the next slide, the sort of larger guidance from the U.S. Public Health Service came out on implementing and managing pre-exposure prophylaxis. There's a couple things that I just want to hit home to you all so that you can take this back to your organizations or consider these things when thinking about PrEP implementation. It's important that PrEP be used in individuals that are confirmed to be HIV negative. So testing is going to be a key component of your implementation strategy. We'll talk a little bit more about that. And all individuals considering PrEP need to be evaluated for other health conditions that obviously might affect the prescribing of any type of medication. So it's really important that that also be a consideration, that evaluation period. PrEP was shown to be effective in clinical trials with other types of adjunct prevention strategies. So that's also something to keep in mind. Remember, this is part of a prevention package that we can offer. PrEP, daily PrEP is really important, so we want to be advocating for our clients that taking PrEP as prescribed is really important, but also taking PrEP in close collaboration with the healthcare team to make sure that all of these different moving parts of patient management is working as it should. Okay, there we go. So again, in July of 2012, the FDA gave its official approval for tenofovir and tricidovine, which is the combination medication Truvada, for daily use as pre-exposure prophylaxis. Currently, this is the only drug approved. I know there's been some talk in the literature about other types of drugs, both that are already approved for the treatment of HIV and some that may be investigational as potential somewhere down the road being studied as pre-exposure prophylaxis. But for now, the approved and effective method of pre-exposure prophylaxis is this combination medication. And then, as I said previously, in 2014, the U.S. Public Health Service released its comprehensive guidelines. So is PrEP right for me? And who is PrEP for? That's probably one of the second most common questions behind why do we need pre-exposure prophylaxis. And there's a lot of guidance out there, mainly guidance that's come from evidence and from our clinical trials that's shown PrEP to be effective. But there are some things that I do want to just sort of hit home. PrEP is for adults who are at substantial risk for acquiring HIV, and again, as we talked about in the beginning, for clients who are HIV negative. Some examples of this group might be someone who's in an ongoing relationship with a positive partner, a gay or bisexual individual who has had, or a gay or bisexual man who's had anal sex without a condom, which is type of a proxy really in practice for high-risk behavior as is being diagnosed with an STD. Anyone who's not regularly using condoms and who may not know the status of their partners, who may have multiple partners, or who may have partners who are at risk of HIV infection. And then anyone, obviously, who's been injecting drugs over the past 6 months, and anyone, as we talked about as well, who's in a serodysphoric couple. Now, I want to put a caveat on all of these things because this really relies, as you can imagine, on our skills as providers, as clinicians, as community members, and as advocates to be able to assess this in our population and to assess this well in our client population. And that's always a big key and always a big caveat because sometimes there's some research that shows that maybe we're not as great as we think we are. So at doing that risk assessment, so we really need to be sure that we're properly assessing our population. PrEP is not indicated for people with HIV infection. People who are not willing to adhere to the protocol that you provided for them. So we want to make sure that people are able to get back to us, that we're able to kind of keep an eye on them over the course of their PrEP management. That's really important. We don't ever want to prescribe a medication for someone if we're going to send them off into the wild blue yonder. We really need to make sure that we have an idea of where they are and how we can reach them so that we can make sure that they're staying safe on the medication. And that people who are not available, as I said, to participate in the diagnostic monitoring piece, people with any type of signs of acute HIV infection, we want to make sure that we're working them up properly for new HIV infection. And then there may be, there's people out there who are using other prevention methods very consistently, very successfully, and medication is not for everyone. It's not a magic pill, if you will. It's not something to force on anybody. So it's just another tool that we have that is very successful. So if we have a patient who's using other methods of prevention very well and consistently, this may not be appropriate for them. Not everybody wants to add something to the regimen. So now comes the big part of the webinar where we talk about, all right, Stefan, well, you've told us everything or some basics about what it is, who it's for, how are we going to bring this into our program, how are we going to make this a reality? And this is really just the very beginning of having that conversation. And there's actually been some research done around what's going on in the community around implementing PrEP. Two really great studies, and I want to throw a pitch out there for qualitative research because these are qualitative studies, meaning that they're not rooted in hard numerical data. These are great qualitative studies that really look at providers' perspectives about implementing PrEP. And one, this Krakauer study looks specifically at HIV providers, which is very interesting, and tried to assess some of the barriers that they felt might be present in prescribing pre-exposure prophylaxis. And many HIV providers said that adherence might be a barrier to efficacy, especially in this imperfect world outside of a clinical trial. Other challenges were, as we talked about earlier, were identifying those patients who are at risk or the best, PrEP candidate. Well, what does that really mean? And risk is a very dynamic principle, so it changes all the time in our patients. So how do we really identify who's going to most benefit from this? And then who should be prescribing this? It was interesting to read that even HIV providers were a little confused about whose purview this falls under. Is it primary care or is it HIV specialty care or some combination of both? One of the things they said is going to help really facilitate this implementation, though, is that there is a great amount of guidelines and motivation in patients, and that this has been proven safe and effective. So there's a lot that's moving this forward, but there's still a lot of questions that we need to answer. When looking at non-HIV providers, this was a great study out of San Francisco Bay Area that looked at 3 different types of healthcare settings, not just HIV-specific settings, trying to get at that we're implementing PrEP and trying to get at some of the things that they were facing. And it was really very interesting. Providers really talked about the need for capacity building, specifically among the care teams, education for providers around pre-exposure prophylaxis, how to monitor patients, again, in this sort of imperfect world that we provide care in. And then current care models might not be sufficient for providing PrEP. So again, some of these, these systems that are set up to see patients once a year for a general medical exam, those kinds of systems might not be very strong in providing this sort of ongoing type of management for a patient. And I think we've all seen that in other types of chronic issues. And then, but all of the providers were definitely in agreement that there's significant public health benefits for PrEP implementation, and it's something that we need to keep pushing for. So in general, what's coming out of a lot of this research is that the role of the consumer, the role of consumer knowledge and prior knowledge is really important. So our patients are playing a very important role in driving this as well. But there are some concerns around side effects and adverse effects, particularly in our patient population. And their questions need to be answered, and we need to be giving our providers and our teams those answers, to that information to be able to answer those questions. The capacity of the clinic, again, as we talked about, is very important. Sustainability considerations are going to be really key, and we'll talk a little bit more about that. And then stigma can be a very significant barrier to retention and uptake, particularly in our consumer population. Some of the recommendations that have come out of some of these studies are combating stigma. It's going to be really key. Increasing our consumer knowledge and support for those consumers as well, not just, come get your labs and come see me. Maybe we need to look at other types of support opportunities. And then training providers, again, on risk counseling, on pre-exposure prophylaxis specific counseling, and then again, really keying in on that risk assessment. So where are we going to go from here? Well, I, as a nurse, and I'm sure many of you have also been trained in this way, anyone who provides healthcare, I think we're always trained to start with the assessment piece and the assessment phase, because we have to know what we're doing, and we have to know our environment before we can make any kind of change. So we want to make sure that we're assessing our population, and assessing our population is going to be really key, because we want to know if this is an appropriate consideration for our clients and for our community. And I'm sure that many of you on this call today have probably already started this process in motion. But you want to ask yourselves, do we have a need? And one of the more important questions, I think, is will we have a need? Because as we saw, we can't always predict what's going to happen in our community. Things change, risks change, and so we have to be attuned to that, and we have to have a little bit of forethought into how we're going to get ready for any types of changes that might happen, particularly from a public health perspective. And then we have to think about, is there anybody who's missing from our patient population but that are living in our community who could benefit? Are there people who are not accessing our services, but we think with a little outreach, maybe they might actually benefit from our from this type of an effort? Just because they're not coming in to see us doesn't mean that they don't need attention and need a champion. It's going to be really important to do an internal assessment as well. So talking to staff and providers, seeing if they're on board, gauging their reaction or their ideas and their knowledge background about this information. How do we get everybody on board? One of the things that I really like to find in a healthcare system is a champion for an idea. And this is usually somebody who has a background or who has an interest. A lot of times when we used to go out to health centers, we found there was a nurse there or a physician assistant or a social worker or a health educator who had done some work in HIV, maybe even back in their training, but they really loved it and they wanted an opportunity to bring that back. And so a lot of times these people can be your champions because this can be their passion. So finding those people are going to be really key. And if you don't have one, is there anyone who's interested in becoming a champion? Finding training opportunities. This is, PCDC offers some great training opportunities, as does the CDC. Continuing to find opportunities that are specific to your system that might involve a little bit more tailored approach. Training for your providers and teams to include everyone, to get everyone on board for this, especially if this is a new initiative. And don't forget training on risk reduction. We talked about how important that risk reduction piece is, and making sure that that everyone is really set on how to do good risk assessment and good risk counseling. One of the other key considerations is going to be revenue maximization, right? I mean, healthcare today is a business, and our business is caring for other people, but we also have to consider our revenue. We have to consider our bottom line. And that's really important, and that's something that your leadership is definitely going to be keyed in on because it's their responsibility to keep things going. So this is going to be really key. So you want to make sure that you're understanding your billing and coding practices. You want to make sure that you're looking internally for services that you're already doing that could be billed or coded differently. And this could be easy or difficult for different types of systems. So it's something that you might need to start with just the very basic of how are we doing our billing and coding so that you can get to the right people to ask the right questions. Making sure that you know your options for reimbursement is going to be really important as well. We want to make sure that we're using all of our providers, our social workers, our health educators to the best of their ability, to the top of their scope, because we have social workers who can bill. We have ways to bill for nursing services, for mental health services. And sometimes we don't always take advantage of those types of opportunities. So maybe in our model, we can have our social worker doing some of the PrEP counseling, and that's a billable service. And maybe our providers are doing the medical piece, and that's a billable service. So all of these things are going to be really important to look at your staffing and look at who can bill for what. And then access, not only to medications, but also to services. As I talked about, PrEP is an ongoing medical management, there's a big ongoing medical management piece to it. So this means that patients are going to be coming back from time to time in your clinic. This is no longer just a once a year sort of how you doing, let's check everything and make sure everything's going okay. Especially in the beginning, you might be having the patient coming back more than once in the first few months, and that always translates into cost for the patient. So it's going to be really important that they have access to the care, and that they also have access to the medications. And don't forget about data. Data is going to be really key and very important. You always want to make sure that you have some means of collecting data that you need. So make sure that you're collecting, can you collect data on PrEP? Is there a way that you can use your current electronic health system, if you have one, to better work for you and do some population management around this subgroup of clients that you're managing? How are you going to monitor your patients? Do you have an infrastructure for bringing somebody back every 3 or 6 months to really make sure that things are going well, and that you're managing the PrEP appropriately, and that they're responding and taking the PrEP appropriately as well? And then dissemination is going to be really important. How can you share best practices? How can we use what we're doing to benefit from funding opportunities? And this is really something that I always hit home with health systems and providers. These types of initiatives are really great pilot opportunities, not only to bring care to people who need it in your system, but also to shine a light on the amazing work that you're doing. Building a PrEP program, implementing it, following the patients, collecting data. If you have the capability to do that and write it up and maybe even do a mini study on it, if you have the infrastructure for that, that's great information to get what you're doing out into the larger arena, which always translates in the end to funding opportunities for the system. So with that, I just want to say that this is really the tip of the iceberg. There is a lot more out there around the science of PrEP, the implementation of PrEP, things that we've learned, and a lot of things that we don't know yet. But again, if you want some of that really more tailored intervention approach, I advise you to, to really contact PCDC and talk to them about how to work on this to make it happen for you, your patients in your community. I put up the 2014 clinical practice guidelines on here as a link, and then at the bottom there's also a PrEP line that you can call. From 11 to 6. It's part of the Clinicians Consultation Center out of UC San Francisco, which is a phenomenal service. So you can call this number, get to talk to some really great live clinicians about anything from the management of PrEP to working up a patient who you suspect might have acute HIV infection, to what labs do I need to order. All of these types of things are really are at your fingertips with this consultation line. So again, I want to just say thank you to PCDC and CDC for allowing me to come and share this information with you today. And with that, I think I'm going to turn it over to Matak, and he's going to lead the question and answer. So thank you all.
Thank you very much, Stefan. I think you really did a wonderful job of outlining some of the issues that folks need to grapple with when they're thinking about integrating PrEP into their services. As we start unmuting the lines and getting ready for questions, there's just a few housekeeping concerns that I want to bring up. One is, if you're not asking a question, please put your phones on mute so that we don't hear that background noise. And also, you should have received, with the registration for this webinar, you should have received a link to an HPAT, which again is that form that we need filled out from you all for our funding, as well as you'll receive an evaluation link. And the reason I'm bringing this up again is a lot of you have been asking about if you'll have access to these slides, and you will get access to the slides if you give us your evaluation and your HPAT. That's the deal we have. So we'd be happy to offer you these slides after that. And with that, I'd like to open up the line and see if anyone has questions. Maybe we can start, Stefan, with, in your experiences, what do you see as being the main challenges when when a healthcare organization is starting to think about integrating PrEP into their services? What are the main places that they get stuck?
I think that's a really great question. I think it's definitely obviously going to vary from system to system, but I think one of the places that most people just get started or just get a little bit stuck on is really even understanding how do we properly assess our population, and is our population really going to benefit from this? Because this is a very big endeavor, and I think sometimes not necessarily getting the buy-in of the system and the people who are going to be implementing this is sometimes a very difficult hurdle to overcome. And I think making sure that the infrastructure and the capacity is in place as to the best of the ability of the system before moving forward. And I think that's seen in practice. It's certainly been seen in the literature. It's very difficult to move any kind of an initiative forward without at least a basis for capacity to start rolling this out. And a lot of places are not going to have a flood of hundreds of patients coming in for pre-exposure prophylaxis. I don't think that's what's been seen out there so far. But I think that, certainly for the few that you might be able to offer this to, you want to make sure that you have processes already in place. I think we know that across the board, there's nothing more difficult than trying to move a program forward without having that process, basic processes in place already.
Thank you. We are having a bunch of questions coming in the chat box, so I'm just going to go through them one by one. Someone is asking if you can think of any successful examples of a healthcare organization that serves as a one-stop shop. I'm assuming this means to service someone's HIV prevention and care needs, as well as potentially other primary care needs.
As said, we opened the line to Justin. He was the one that answered that question. So Justin, if you want to clarify anything, we can probably hear you now.
Yes, can you hear me?
Yes.
Oh, yes, hi. Okay, thanks. Yeah, my question was just great presentation, and just wanted to hear some best practices along sort of for patients, clinicians, and maybe healthcare as far as how PrEP has been able to roll out, and in the context of whether it's a standalone organization, let's say like a CBO providing a certain kind of PrEP support service or PrEP awareness, and then a clinician at a clinic somewhere else is doing something else, or are the examples more in a one-stop shop like a federally qualified health center where you have a coordinator and the clinician and et cetera? So that's my question.
Right. Great question. Great question. And the simple answer to that question is that there's no simple answer. But I can tell you that there's a lot of different examples out there of programs that have worked very successfully. I don't think there's a critical mass of evidence to show that one works better than the other, if that makes sense. I've certainly seen practices that are, one or two providers, physicians, or a physician group that is, just a smaller practice that is successful and has been, and, many of these providers have already been providing HIV care or care to have experience with caring for at-risk populations, specifically gay, bisexual men. And so I think that they already sort of have infrastructure for ongoing monitoring of HIV-positive individuals, which can translate into ongoing monitoring for patients on PrEP. So I know there's some successful practices that are smaller that have just sort of like, boom, integrated this practice into all their other practices. Be that as it may, one of the studies that I talked about in the slide looked at three practices in particular. One was BayPAC, which is a Bay Area Perinatal AIDS Center in San Francisco, and that was a very specific population. Obviously looking at perinatal potential for perinatal, not transmission, but in that population. And so also looking at Kaiser Permanente and looking at a rollout in San Francisco City Clinic, which is an STD-focused treatment clinic. So Kaiser Permanente obviously being HMO, being a much more, sort of larger primary care, preventative care focused system, all of which had successes, definitely some barriers, some of which we talked about. But I think, again, there's no one formula for delivering this type of care. I think what you have to do first is sort of look at your own infrastructure and see what works, what might easily translate into the ongoing monitoring and counseling piece. And then, work on getting providers trained in how to prescribe and manage some of the potential side effects of these medications, and then how to manage the patient on ongoing PrEP. So, I know that's sort of a roundabout way of answering, but there's not really a specific pattern out there or a specific structure out there that's been more successful than the other. I think you just have to sort of look at what you have going on already and how to sort of implement and build capacity around that.
All right, great. Thanks, Stefan. We have a couple more coming through. The next question is this treatment covered by insurance, and what happens if the individual is undocumented or has no insurance?
Great question, big question. So to my knowledge, PrEP can be covered by insurance, but I think insurance very much varies. And I don't know, honestly, I'm not exactly sure, because I know that there are different stratums of copayment and financial obligation for patients who are looking to get PrEP and obviously Truvada covered on their insurance. Because it is FDA approved, that then opens the door to being covered by insurance plans. I think it's going to vary in terms of the patient obligation. For those who are undocumented or who are not eligible for insurance, I believe there may be a route through patient assistance programs to get some coverage for these. I don't think, I may be wrong, it's been a little bit since I've used patient assistance programs, but I don't know if they cover undocumented individuals. There might be a bit of a way around that, but I don't think so. It depends from pharmaceutical company to pharmaceutical company, and I'm not exactly sure what Gilead has done, but I know that in general the patient assistance programs I think are looking to assist with this. The other option, of course, is to look for any type of study that might be going on or any publicly funded program that might have some ways that might be offering PrEP to maybe partner with or look at building a relationship there.
Great. Those are some good ideas. The next question is, how long does a person at a high risk have to be on PrEP before it begins to be effective?
Great question. Great question. So PrEP is effective pretty much from the get-go. Once people get a level of medication in their blood, you know, that the PrEP Truvada itself in particular has quite a long half-life, which is why you only have to take it once a day. So levels can get pretty high, and at the what we would call in treatment therapeutic, but what we call for prevention, you know, at the proper level to prevent HIV infection very quickly. I mean, there's even, I think, a little bit of evidence coming out that some intermittent, taking PrEP intermittently might be, you know, beneficial as well, although that's not advocated for. Daily use is what's advocated for. So I think it's, I think you know, it's one of those things where you can take it, you know, you prescribe it on Friday, Saturday, Sunday, they take it there at the protective level.
Thank you, Stefan. I think that was among the last of the questions that we had for now. As I mentioned earlier, Stefan has graciously agreed to stay on a little longer if folks have additional questions, but I did want to make sure to close out this webinar for the folks that need to leave. So if we can move on to the next slide. As Stefan mentioned, we definitely are able to discuss with you how to bring PrEP integration specifically to your own healthcare organization through our free capacity building services, and we are one of many organizations that provide this kind of work through CDC. Here's our contact information, our phone number, and our email. And in reference to the question someone had around reimbursement, I think it does really differ location to location. That's some of the stuff that we can help people navigate through if you want to contact us directly, or put you in contact with another one of our colleague SEBA providers who may have more experience in whatever the topic is that you're requesting support. But I did want to thank you all for joining us today. Please look out for our other webinars in the future. And again, we will stay on the line for a little bit longer to answer any remaining questions you all may have. And thank you again, Stefan. It's really been a pleasure.
Thank you.
So unless you all have any questions, you're free to log off. But if you do have questions, let us know, and we'll either open the lines or answer whatever in the chat box. Thank you very much.